All right, so today we're taking care of a 66-year-old male. He has a medical history of hypertension. He's a former smoker and hyperlipidemia and insulin-dependent diabetes. He actually had a STEMI in 2022, had a couple stents put in the RCA, and then had a couple stage PCIs to the LAD. He does have a severely reduced ejection fraction, but otherwise has normal kidney function. He presented to us with bilateral lower extremity claudication, and because of his cardiac disease, we ended up treating him medically for quite some time. ABIs when we first met him were zero point 0.5 and zero point 0.6, and we did an arterial duplex, which showed a elevated peak systolic velocity in the mid-right SFA with a peak systolic velocity of over 300. Distal to that, he had reduced systolic velocity, and in the tibials, in the AT and the PT, had absent Dopplers. So
So he's obviously optimally medically managed, and you saw the iliac pictures. There's nothing going on in the SFA. You've got a moderate to severe calcified SFA with very, very poor flow. It's not really because of his heart failure. You can see that the distal vessel actually fills prior to the flow in the SFA coming down, which is going to be part of our algorithm on what we're going to do. So you can see again, I'm going to let it run. Profundo fills quite briskly. However, you can see the SFA flow is very, very poor. You got a large genicular collateral filling the distal popliteal, and then you can see here that you do have a 2.5 vessel runoff with a very significant osteotibioperoneal trunk lesion with an occluded, anterior tibial artery. And then down into the foot, you can see that obviously he's got a peroneal artery that's open, and then he's got, and then you can see the dorsalis pedis comes back, and then you can see obviously you have a good posterior tibial artery. So our plan today is to go ahead and intervene on this, and we'll talk about our choices. You can see there's some good close-up pictures that Dr. Ibrahim took, Dr. Ali took. You can see you get the tight mid SFA with the 300 plus velocity, and you've got a distal occlusion right around the C of the CSI tape. And you can see here's another shot of the occlusion. You can see that there's a slight beak with a large the genicular collateral, as you see, at the level of the popliteal. So we're going to go ahead and cross this now. So we chose an 014 wire to go ahead and cross. I'm just going to go ahead and put a roadmap up to give you some. Don't move. Okay. Just going to put a little roadmap up just to show you the flow. And then you can see the flow is very poor. You can see the occlusion, like I said, short segment, but that's not the reason why I'm demonstrating the case. We have quite a few things to talk about. So you can see Dr. Ali has chosen what we call as an 014 wire, called a command wire to probe. And you can see that the command wire looks like it's not even occluded, probably a very tight stenosis, and has crossed miraculously, which we knew would, that's the lesion. Okay, another lesion distally. And again, you can see here, he's going to have to track the catheter down. We've got a support catheter. Unlike the coronaries here, we use 035 systems because we want to save money. This is a 100 or less than that $40 catheter called the Aqua Tempo. And then we're going to go ahead here and get that close to give him some support to be able to cross this lesion. He's going to have to get into that lesion here to be able to cross. So you can see here, he's going to pop into that area. He's going to give himself some good support. And then once he's there, he should just pop through with this wire. Likely, let's see whether it goes. Took it a little too close. I probably wouldn't have gone that close because you want the wire to actually work. And here it looks like this is the occluded segment. So at this stage, he's going to play for a little while. And then before he dissects, maybe we'll just switch off to another wire here. Give us a Confianza wire. Let's do with the coronary wire here. Short segment occlusion. I think the hydrophilic nature of this wire, the lack of tip load, is causing it to not quite function the way we want it to. So we're going to try to cross here, and likely we're going to cross without a problem. As you see, the tip gram load wire really kind of seems to go and find the channel that we want to find. I'm just going to go to another view to show Dr. Ibrahim where we are. Watching these.
Mm-hmm.
Okay. So creatinine is normal, but even then we don't want to give too much dye, as everybody knows. So we're heading okay. I should be able to find the lumen. Let's see. So we're going to just hopefully find the lumen in a second. And we have found the lumen, as you can see. Looks like we have. No, maybe not. Some of these short occlusions can be tricky in the sense that, this seems to be maybe sliding on top of the vessel. So in this kind of situation, let's see how it goes. You don't want to extend the dissection plane too far down and too far past this. Does it feel real or no? It feels pretty good, right? Or no,
Yeah.
it's not behaving. So pull back, redirect. So we're going to pull back and redirect the catheter to another plane, and we'll try to go. So what I'm doing is just getting a quick loop and just doing a loop re-entry technique since it doesn't seem to want to work in any other direction here. So there's my loop. So you can see how fibrotic this is. The loop is not even cracking. There it goes. Looks
Did it
like.
right.
So we just crossed the lesion. Show me down now. So we just crossed the lesion. You can see we're in the lesion. We're across the lesion now. So now I'm going to just go ahead and what we're planning on doing is putting a filter down. So can I have a
Bare
Abbott filter? The reason again we're using a filter is our vessel runoff is very, very poor because we have a perineal lesion, and we also have this slow flow in the vessel. So I'm just going to go ahead and take this wire, which is the
Bare wire.
18 the bare wire, which is the wire that comes with Abbott. When you put this wire in, you have to be very careful because you want to make sure that the tiger side of the wire, there's one side of the wire that has the tiger stripes. That's the one that's distal, because the proximal part of the wire, which is shape, is the wire that has a little golden, I would say, nugget on it that prevents the filter from migrating. The beauty of this wire is that the migration of the filter is independent of the wire, meaning I should say its movement of the filter is independent of the wire, which prevents the filter from moving while you're doing complex, interventions with atherectomy, so on and so forth. So there I've put it in the posterior tibial artery. Now I'm protecting it all the way down to the foot. That's good. That's good. Now we're going to walk it back. We're going to do a quick filter and then a quick IVUS.
We're gonna
Okay.
018 IVUS.
Okay. So let's get the filter down. So the embouchure, like I said, this part of the wire has the tiger stripes. You can see black and white. So this way you know that you're on the right part and the filter won't go flying distal. The beauty of this is as you're doing these lesions, you don't have to worry so much about the filter moving and causing dissection. The disadvantage of this filter is that the capacity of the filter is less than the spider. So if you're expecting large volume of thrombus or debris to come down, this may not be the filter to use. But the beauty of the filter is that it's independent of the wire. Floor, please. And because it's independent of the wire, you're able to move bulky devices back and forth without a problem. So I'm going to deploy it right about there, and it's very simple. It's just pull off the red tag and deploy the filter. So there's the filter. We're just going to bring it back. Now we're going to do a quick IVUS. So I'm starting with IVUS in the popliteal. So start recording, please. Okay, so you can see as you see the IVUS, it's a good sized lumen. I'm just pulling back slowly. And as I'm pulling back slowly, you can see there's not much thrombus there. And then you can see a lot of soft plaque. And then you can see there's the area of occlusion with what looks like soft plaque and pretty much occluded around the catheter. You've got to think there's underlying thrombus there at some area. And then you can see the different areas of stenosis. And as I pull back, you'll see again a calcified lesion, very tight. and then really pretty clean up to you get to the prox. There's some floating debris, likely thrombus at this area, and very tight in that area, likely thrombus again. Very speckled in appearance. This is fibrocalcific plaque. Okay, and then so you have fibrocalcific plaque mixed with thrombus with, there's again, see that speckle and see how it's moving with the vessel? So that's layered thrombus for sure. And that's part of the reason why the embolization occurs. You can see it there, and that's part of the reason. You can see the long set. Look at that. Look at the level of speckled thrombus there. Liz, can you talk to him, please? No, 1 second, sir. And then you can see here, good flow, and then the lumen all the way up to the top. So because of our clinical suspicion, his flow dynamics in the vessel, and also the fact that we have an IVUS that's very suggestive of layered thrombus, we're going to go ahead and run a newer thrombectomy catheter. It's called the JEDI. The JEDI is basically a mechanical lavage thrombectomy, I would say. It produces a jet that comes out at the tip of the catheter and then goes ahead and goes ahead and also does aspiration at the same time. So we're going to run this through. So we're just going to do this slow aspiration of the lesion. Let it do work. It doesn't aspirate straight blood, and because of that, you're going to have, it's going to look like you have a lot of blood inside the container. It's about 2/3 to 1/3, I guess, like saline to blood. So therefore, it's really the technique of aspiration that's very, very important. So you can see here we're going very, very slow and allowing the catheter to do the work and really allowing the catheter to suck all the thrombus out. I know I have some occluded segments, which I'm really not trying to push through, but I'm not trying to let the catheter kind of work its way through, which it's trying to do. But in this area, it's not. So I'm just going to let it sit. There it goes. So I'm just going to let it sit here and let it just aspirate as we go down. It's lavaging and aspirating the vessel. And then as you can see, I'm just going to try to take it through the occlusion and see whether we can easily aspirate the vessel and make it look really, really pretty. And remember, we said it was by the C of the CSI that the occlusion really starts. And you can see it's very, very soft plaque with overlying thrombus, which may or may not be able to work here. And we're able to pop through it. Okay, now I'm going to let Dr. Ali just walk it back. So now we're going to inject and see what the flow looks like. And look at that, guys. See, the flow is better now through the SFA and not through the profunda.
Without a single balloon.
And you can see here now, you've actually been able to inject. We've actually been able to clean out the majority of the underlying. See, look at that. So even though the SFA has significant lesions, you've been able to aspirate out all the clot and all the debris that was slowing it down, and you can see the before and after picture. So anyway, so now we decided to do a directional atherectomy, which we're doing. So, and I want everybody to see the flow difference in the vessel. You know, the difference in the vessel shows, again, how the utilization of intravascular ultrasound can help you to prevent complication and to choose the device. So obviously we know that it's a long segment occlusion. And what was our reference vessel diameter, guys? 6. It's a 6, so we're going with a Hawk M, which is aggressive. And I'm only going to cut the areas that are occluded. I'm really not going to go crazy here. So I'm coming down. I'm just going to pick the quadrant I want to cut. Okay, I'm cutting medially here. Turn it on, please. So I'm just going very slow. Off. I'm going to stay in that quadrant. I'm going to come down to here. On, please. Off. And then I'm going to go down distal past the CSI. I'm going to go right about here. It's okay.
Come off roadmap.
On, please. Stay there. Oh, okay, it's okay. Off. We're going to do a quick IVUS back. So again, starting distal to proximal. On, please. So record. So I'm just pulling back here the IVUS, and you can see here, very good resolution, good lumens, about a 5 to 6 millimeter lumen. And again, that's the occluded segment, a little bit of dissection there. But you can see that the lumen has gotten much bigger with our atherectomy device. Clearly, probably can do more cuts here. But clearly, I think with the two lumen cut, we've done a pretty good job. So it looks like really going to have to cover this whole segment. It looks pretty diffuse in this area. It's not like you can leave one particular area. So I'm going to try to go from healthy to healthy. Let's get a serenader. So we're going to go up
So
here.
going up to a pressure of 4 first, just to engage the blades. And I'm at 4. We stay up for a minute,
So we
allow the
keep it up
blades
at
to do
4
their work.
atmospheres for a minute. Just going to walk this back now. It's certainly much better flow, right? That we're happy with. Now we can, so we're definitely happy with that. So now we're just going to go ahead and take care of this with a quick Sapera. Could argue to leave it, but I think we should send it. It's pretty complex, around 30. All right, so we're going to go with a Dorado, and then we're going to balloon it, and then we're going to go with a Sapera, and we'll be done in a sec. So now I've got a command wire down, and I'm just going to go with a Dorado. And then we're going to just balloon across CSI, and then we're just going to put a Sapera there. I think we'll be done in a second. Well, 14. So really open it up. We go high pressure down. And now that it's down, we're just going to walk it out. Get the Sapera ready, please. So you can see that the distal end is going to come out slowly, and Ibrahim is just going to allow it to flare. Just going to allow it to flare just around there. Yep, you're going to allow it to flare. There you go. Very nice. Very nice, slow, disciplined throws. Prevent the stent from expanding. I mean, from elongating. And there's the lesion right on top of the CFCSI. And he's just going to deploy it now. So it's 10, 20, 30, 40, 50, 60. It's a perfect deployment. Perfect. Good. I think Sapera, when deployed properly, is a very effective device, and you can see the flow is fantastic. So I think we're done here, and we're going to IVUS at the end and then take it from there. Just going to take another balloon angioplasty here just so everybody can see how everything looks, and then we're done. So that area right there, we'll probably have to stent after doing an IVUS, and we'll take a look and we'll decide. So with that, we're going to sign off here in New York. I hope that was helpful to you. Thank you again. I really appreciate you allowing us to be part of your education. And we'll see you next time. Bye-bye. Thank you.